and community leaders. We are at the forefront of creating and distributing impartial and impactful research to understand the way individuals process reproductive losses, so global standards for offering compassionate care. Our quarterly Research Reveals lecture series features in-depth discussions with the authors of some of the latest groundbreaking reproductive loss research. I know this is a sensitive topic, since so many of us have been personally impacted by reproductive loss. I just want you to know that I'm mindful of that and will be as tender as possible. We're here to support you. In fact, if you find yourself experiencing troubling emotions, or maybe you're thinking of someone who you'd like to support, please consider the following resources: miscarriagehurts.com and abortionchangesyou.com. These are anonymous interactive healing websites for men, women, family members, and friends impacted by miscarriage or abortion. You may also consider checking out IDA.org, that's Pregnancy Loss and Infant Death Alliance, and griefshare.org, as well as our helpful toolkits that will help us with supporting anyone who's impacted, which are available on lifeperspectives.com. I also encourage you to join our guest speaker in breaking the silence about perinatal loss by joining her in Project Poppy Seed. You can learn more at projectpoppyseed.org. I encourage you to take a look at all of these great resources after the event. But for now, let's introduce the author of the Trauma Care article, The Trauma of Perinatal Loss, a Scoping Review, Dr. Nikki Berry. Dr. Berry is an assistant professor in the College of Arts and Sciences at St. Martin's University, teaching undergraduate courses in nursing theology and philosophy, palliative and end-of-life care across the lifespan, and acute care management. Dr. Berry's research in perinatal loss, grief, and bereavement focuses on decreasing the emotional trauma parents in the wake of a life-limiting fetal diagnosis. She has been published in multiple referee journals, including the Journal of Neonatal Nursing, the Journal of Obstetrics and Gynecological Nursing, Journal of Hospice and Palliative Nursing, and Death Studies. Her research has been presented nationally and incorporated into international perinatal palliative care curricula. Dr. Berry, as I've already mentioned, is the founder of Poppy Seed, a nonprofit organization dedicated to raising awareness, providing education, and conducting research in perinatal loss, grief, and bereavement. Dr. Berry, thank you so much for joining us.
Thank you so much for having me, Michaeline. I'm honored to be able to share my research with you and your audience.
That's wonderful. Oh, and speaking of those who are participating, feel free to submit questions throughout the presentation. You can do that in the Q&A box, and we're going to get to as many of those questions as we can in the final 10 minutes. So without further ado, let's jump right in. So, Dr. Berry, could you tell us what this topic is important?
Absolutely. And before I do that, I would like to define some terms that I'm going to be using throughout this talk so that everyone is on the same page. When I refer to perinatal, I'm talking about the time frame between conception and 28 days following birth. So perinatal loss occurs within this time frame. And rather than using clinical terminology such as zygote, fetus, neonate, I'm going to be using the term baby to the one who is within that time frame. So yes, why is this topic important? The prevalence, I think, may be one of the most significant aspects of the perinatal loss experience. This is a worldwide phenomenon. And in the United States alone, 2.4 million babies die in that perinatal period. And to put this into perspective, when compared to cancer, perinatal deaths are 4 times greater than the deaths that occur from cancer every year in the United States. So not only is this a loss that occurs very frequently, it's also a very impactful loss to the parents, the families, and then the communities where this occurs. There are multiple adverse outcomes associated with this type of loss. And there's also a silence which shrouds this loss. Because it's an uncomfortable thing, we don't like to talk about it. We don't like to think about it. We like to believe that babies are not going to die, that parents outlive their children. And by acknowledging the fact that babies can die, we are caused to question how we believe the world works. So rather than acknowledging it, it's easier to push it aside and to never think about it. So those without personal experience have a very hard time understanding what it is that parents go through. And because so many individuals experience this type of loss, that's why it's important to talk about. It's silent. We need to talk about this so that we can understand how to support parents in this experience.
Wow, thank you, Dr. Berry. And that the prevalence is kind of shocking, isn't it? And but when you think of the silence that you just described shrouding it, I guess that's part of it, right? This lack of understanding. So throughout your the paper, you talk about a trauma lens, and thank you for defining terminology when you started. And so I think it'd be helpful too for those who are participating to understand what you mean when you say a trauma lens.
Absolutely, great question. Thank you. When I'm talking about a trauma lens, I refer to a way in which we view the world. So I'm sure many of you have heard of the term rose-tinted glasses. That means if you look at the world through rose-tinted glasses, you see and experience the world in a certain way. It's influenced by the lens through which you view that world. Well, that's the same with a trauma lens. By viewing perinatal loss through the lens of the trauma lens, healthcare professionals and even members of the community are able to recognize the potential for traumatic emotional trauma within that experience. And then by recognizing, respond to the parents, be able to address the needs that they have within this situation. So this is a way of looking at the perinatal loss experience, which can influence how we respond.
That makes a lot of sense. Thank you. Okay, so the scoping review. I think it'd be really helpful if, I don't know if everyone's even familiar with what a scoping review is. So I'm going to tell us what it is and help us through, like, what does that process look like? And if you're able to too, I thought maybe in that, giving us a little bit of a summary of the data sets from the selected studies.
Absolutely. So clinicians, scientists, healthcare professionals, when there is a question about how something works, we look at the literature, what studies have been done. And in looking at the literature, it's important to have a type of framework to guide us so that we're not blindly searching through thousands and thousands of articles. A scoping review is a type of framework that individuals can follow as they are trying to answer a specific question. So this process is very good for areas in which little is known. It helps the author or the researcher or the individual to have a set of steps to begin asking questions and understanding something that they're searching for. So the process, it begins with a research question. And in this article, my question was, what is known about trauma within the perinatal loss experience? Once that question is defined, then different search criteria can be entered into databases that hold the research articles from many, many different researchers across the world. The search process, articles are filtered out using predetermined inclusion and exclusion criteria. When articles are identified that are applicable and helpful in answering the question, they are then consolidated, interpreted, categorized, and then summarized. The findings are summarized and distributed to a wider audience. So about the data sets that were within this article, there was actually a wide range of different types of research, both qualitative and quantitative. So those who are not familiar with those terms, qualitative methodologies or ways of conducting research are typically smaller studies, and the data is collected through interviews with individuals who have had a certain experience. Now, because these sample sizes are relatively small, maybe anywhere from 5 to 30 individuals, The findings cannot be generalized to a larger population. But the findings are very important because if there's not much known about that topic, it gives those researchers a starting point. It lets the researchers know those important topics that need to be further investigated. Once that's established, then those quantitative researchers who collect large data sets using typically questionnaires in this case, can then distribute that information to a wide range. One of the samples included in this article, there were over 450 participants who responded to a survey. And that helps to understand, are there more individuals with this particular experience? Are the situations similar? Is there anything that's the same, anything that's different? And it helps us to understand what individuals go through in this particular phenomenon, in this case, perinatal loss.
Wonderful. Thank you for taking us through that. And remind us that the number of articles or studies that you met your criteria to include with your scoping review.
Yes, 15 articles were included in this review.
Okay, fantastic. And you note that across those 15 studies, and it's interesting, right? You had said the different qualitative, quantitative, and the different data sets that were used, that you saw the emergence of 3 content categories. And so I think if you could walk us through each of those content categories, doing it one at a time. And so I think the first you had listed was prevalence of trauma.
Yes. So prevalence of trauma, when you are looking at what is what happens with trauma, what trauma occurs within the perinatal period, it's important to understand if emotional trauma is common within that experience or if it's an exception, if it's an outlier, if there's something else involved. And within this article, looking at the smaller sample sizes all the way up to those very large data sets, researchers were finding that anywhere from 25 to 60% of the participants were experiencing post-traumatic stress disorder and symptoms of post-traumatic distress. And that is particularly concerning for several reasons. For one, there's a very wide range. So the question emerges, why is there such a difference? Why is there that anywhere from 25 to 60? And the short answer is it's not commonly measured. So it's exciting that some of these larger studies did specifically measure symptoms of trauma because it helps us as researchers, as healthcare professionals, to see that yes, this is something that occurs within this population. Up to 60% of individuals experience emotional trauma. The other thing that's important about this is when you look at populations who experience loss outside of the perinatal period, such as the loss of a spouse or a parent, a close friend, even a child, the prevalence of these symptoms of post-traumatic stress are 4%. So there is a large difference between perinatal loss and losses of other natures. And again, that raises the question, what makes this type of loss unique? Why is this type of loss so susceptible to emotional trauma?
Why? That kind of takes my breath away. I mean, those numbers, and just thinking of those individuals, again, going back to you talking about kind of silently hurting, and being impacted this way. So the second category that you had noted was the characteristics of trauma. So you can tell us a little bit more about that.
Absolutely. So within post-traumatic stress disorder, there are specific characteristics that an individual experiences. To be diagnosed with PTSD, the individual must meet these diagnostic criteria. Some of those things are triggering events, flashbacks. They can be episodes of anger and hostility, dissociated events. So these are symptoms that are experienced with post-traumatic stress disorder as we know it within the clinical practice setting. And looking at the characteristics of trauma described by the participants, many of these men and women were experiencing a sensation of being completely dissociated, some for up to a year after the loss experience. Others described feeling stuck and unable to move forward. There were many symptoms of anger, hostility. There was loneliness and isolation, difficulty interacting with others and maintaining relationships within the social circle, with parents, with spouses, with children, with coworkers, difficulty sleeping, eating disorders, dizziness, headaches, hypertension, diabetes, cancer, depression, anxiety. I mean, it was actually quite heartbreaking to see all of these very life-altering and sometimes devastating symptoms that parents were experiencing. And again, it wasn't outliers. It wasn't this small subset of 2 or 3 individuals. Within the study, across the studies, there were multiple individuals experiencing these symptoms. And often these symptoms were debilitating and disruptive of daily life. So individuals struggled to fulfill their daily roles as a parent, as a coworker, as an employee, as an employer. And the characteristics, it was very important to identify these so that we can see as healthcare professionals, what is it that these parents are feeling? What are the struggles that they're occurring? What health, both physical, emotional, spiritual concerns do they have? So by recognizing those, we can then begin to address them.
Thank you. And then the last category that you had seen across these studies, you have called them key milestones, and there were 4 different milestones. So perhaps you could kind of slowly unpack each of them for us.
Yes. A milestone is a significant event within an individual's life that triggers change. Now, we all undergo milestones. Milestones are going to kindergarten, getting your driver's license, graduating from high school, getting married, getting divorced, experiencing the loss of a loved one. Each of these milestones, they disrupt the flow of daily life, whether in a positive or a negative way. It is some sort of change that comes about. Within this change, the individual is going to adapt. And what's important here is to understand that this adaptation to the change triggered by the milestone can either be healthy or unhealthy. And within these milestones and triggers, the healthcare professionals have the unique opportunity to intervene and support the individual to promote healthy coping, healthy changes, and to potentially prevent unhealthy coping or unhealthy changes. And so these key milestones across these 15 articles, parents were very specific in these 4 areas being an area of change, that milestone. So diagnosis was the first one. That is diagnosis of the pregnancy no longer going to result in a healthy live baby. And in order to learn of this diagnosis, it has to be communicated to the parents from a healthcare professional. Within that experience of learning of the diagnosis, parents often entered into a stage of fight or flight. And so within that, the brain changes, the physiology of our brain changes. We have evolved to be able to survive. And when something threatens us like that, all we can think about is surviving. We can't think about things like processing information or making decisions unless our decision is I'm going to run away or I'm going to fight it. So it's important to understand how the physiological response is occurring within the individual as well as the emotional response, because at this key milestone, this process of communicating the diagnosis, parents are going to have they're going to have to adapt to it, and they are going to need to make decisions and need to move forward. And this is one of those areas where it's a critical time period. Parents can move forward in a positive way, or it can be negatively impacted. And again, those healthcare professionals have a very key role in promoting that positive experience within a traumatic event. Some of the things that parents reported as being helpful were things like having a listening ear, being allowed time to process the information, not being pressured in any way. And parents also reported being traumatized and re-traumatized during this experience, often by the way it was communicated, the words that were used, the body language that was portrayed. The second milestone is the delivery and birth. So whether this loss occurs from miscarriage, stillbirth, neonatal death, there is still the need for that baby to no longer be in the womb. And this, again, was commonly an emotional experience for parents. And the clinicians, healthcare professionals, had a very impactful role in how they helped facilitate that process. One of the things that stood out to me as I was looking at this, the etiology of loss, whether it was miscarriage, stillbirth, neonatal death, that did not matter. The characteristics of the trauma symptoms were the same across any type of loss. The prevalence was the same across any type of loss. Now, this can be difficult for those without prior experience with perinatal loss to understand, especially in cases of early miscarriage or perhaps an ectopic pregnancy. There's a lot of medical procedures that surround this, and it's easy to lose the emotional aspect of that birth process within it. Now, it's also a possibility to make that a positive experience. So some parents, it was very moving reading their stories about their birth experience. One woman shared that she wanted to have pictures of her baby, and she had gone through a very traumatic birth process and had a C-section and a blood transfusion, ended up in the intensive care unit. And her nurse told her that she was going to braid her hair and the pictures weren't going to be in that bed. They were going to be meaningful and special. And so there was just that small thing that the nurse could do to really have an impactful memory for that woman and her family. And those pictures are so much more special because not only do they have the pictures and memories, there was the kindness attached to it, the kindness associated to it. Now, the third is interacting with others, and this extends to the social circle of the parents. When there is a pregnancy, society expects it to result in a live birth. When others know about the pregnancy, those in the social circle, they ask about how it's progressing and if the nursery is, coming together, is there a baby shower? And the parents have to then tell their friends, their family, their children, this baby is no longer with us or is not going to be coming home with us. And so communicating that information was very difficult for the majority of parents. This responsibility also commonly fell upon the fathers. So not only did they have to communicate this difficult news, they had to process how others responded to them. And some had a positive experience, and fathers reported a positive experience, but unfortunately many reported negative experiences from those within their social circle. Again, this lack of understanding of the emotional impact of the experience, and then the desire to not talk about it, to not know it, to not be a part of it. And so there was that lack of support from the social circle. Many negative comments were made, insensitive comments, and not always maliciously, but different things like, you can always try again, you're young, at least you never held the baby, different things like that, comments that the individuals, as well-meaning as they tried to be, they were very hurtful and impactful to the parents. And so this was a key milestone that progressed over time, because it's not a 1 minute in time that parents share this information. They have to share it and reshare it and reshare it. If they have living children that were excited about their sibling, there's those questions. Why isn't baby coming home? Depending on the developmental age of the child, trying to explain to them without traumatizing the child, but also dealing with your own emotions. It's very, very complex. It's very complex. And then the final milestone is the time frame following the loss. And that could be the minutes, days, weeks, even years following the loss. Very rarely did parents receive follow-up care within the healthcare profession because there was not a baby to be seen, to be followed. Parents fell through the cracks and they didn't receive the support they needed. So many of them either did not receive support or had to search it out by their own means while trying to understand how to live in this new reality without their baby in this new world that doesn't follow the rules that they thought it followed. You know, babies can die and it's not fair to them. So they, some of these symptoms persisted for years. In one of the studies, the researchers followed the parents for 5 years, and those symptoms of trauma persisted for those full 5 years. In another, the symptoms of trauma and complicated grief persisted for 12 years in both men and women. So it's not an isolated event. It is a new life that these individuals are living, and they rarely receive the support that they need in those years following.
Right. Well, thank you. Thank you. It's a lot to take in, but so helpful. And it strikes me as you're moving through the key milestones that all of us in some way play a role, right? So there may be the healthcare professional, right, involved with the diagnosis or the delivery and birth. But there might be mental health clinicians that are intersecting at some point. But then when you talk about interacting with others and what happens after, that's all of us. That's all of us with family, friends, and colleagues. So I'm wondering then if you could, like, what are the practice implications of what you found doing your scoping review?
Fantastic question. And yes, like you said, it kind of brings us back to why is this important? It's important because it impacts all of us, not just the healthcare profession, but the individual walking on the street. One of the big things that comes from this is allowing individuals to talk about their experience, giving permission to these parents to share their stories, whether you are a nurse, a physician, a social worker, a therapist, a chaplain, a sister, a parent, a brother. Just ask them, say, I want to hear about your baby, or say, I remember your baby died however long ago, maybe a month ago, maybe a day ago, maybe 10 years ago. I've had individuals approach me who are still deeply grieving their loss 40 years later. So giving that permission to talk about the loss is incredibly important. Inside the healthcare profession, recognizing that that loss is there, and then viewing it through that lens of trauma, recognizing that there may be persistent symptoms regardless of the time that has passed, regardless of the live births that have occurred in the years that have passed as well. So just that recognition and actively asking about it, that can be very, very powerful and very meaningful to the parents. And it also opens that conversation to providing the resources that parents need. Now, some parents may have found a way to cope on their own. They may be just fine, but many are not. According to these statistics, up to 60% of parents are not okay still, and they need our support. Language that is used when talking with these families, with these parents, is very important. I know for myself, I'm guilty of this, and as a healthcare professional, delivering bad news, communicating bad news is incredibly uncomfortable. And it's so easy to slip into this protective shell of using medical terminology, of using acronyms, of using jargon. But when we're talking about this, the parents aren't from this medical background. They don't understand what we're saying. So taking the time to slow down and to use words that parents can understand and words that are sensitive is so important. Mimic the words that the parents are using. If they are using the word fetus, then the word fetus is appropriate. If it's being referred to as a baby, then baby is appropriate. If the parents have named their baby, ask about that. Have you named your baby? May I use your baby's name? Personalizing this experience, letting them know that the bond that they have formed is normal and that you recognize it and acknowledge it. Remembering the dads is also incredibly important. Fathers or the partners are often very, very disenfranchised and marginalized throughout the experience. In fact, there was a quote from one participant in the study. This dad said, "It was my third or fourth miscarriage before someone in the hospital even thought to ask if I was okay." And remember, it's the dads that are sharing this news with others. It's the dads that are supporting the moms, the partner who's given birth. It's those partners who are not giving birth or carrying the child, but they're very much involved and often very emotionally involved as well.
Right.
And there was a story that stood out to me in particular in my dissertation research. I was speaking with a father whose twin daughter had died of anencephaly when the brain didn't form 12 years prior to being interviewed. And the grief was still so raw in the conversation and his words, and he cried throughout the interview. And afterwards, I asked him, who do you have to talk to about this? Because there's still so much you're carrying. And he told me that I was the first person to ever ask about his daughter in the 12 years after she had died. And so there's these stories that people are carrying for decades, some of them, and they just want to talk so badly about it. And it was interesting, about a year later, I was speaking to his wife, and I had interviewed her as well. And she shared with me, she's like, "I don't know what you said to him. I don't know what he said to you, but he's a different person since you interviewed him last year." And it was just that permission to share the story is a powerful change, and recognizing the grief that someone experienced can be life altering.
Right. Wow. So giving him that space to do that. And how wonderful that you were able to have that follow-up with the wife. I think sometimes, like, when someone is sharing their pain it's so difficult for us to listen to it. And then you sometimes almost wonder, are you helping, or are you making it worse? And so for you to be able to say, no, actually we are, you may not see in that moment, but we actually are helping that person in doing that. And you've already kind of slid right into, you talked about practical implications of this practice for those who are healthcare professionals, but you've already talked a little bit about what we can do. And I think, even though I'm going to guess most people who are participating today are professionals and in some form around this, but I'm sure we're all thinking of a family member or a friend that we want to support. And so maybe you could give us some additional tips on how we can provide support for them at the time that the loss is happening, but also like kind of this where he said, no one's asked me in 12 years. Like, how do we break the silence if maybe we've known about this, but it's been a long period of time? So if you kind of do both ends for us.
Yes, absolutely. It is a difficult question because, especially in this culture in the US, we're taught, don't cry, don't bring up anything emotional, don't talk about death. But it's so important for healing, and it's so important to let people know that we notice their pain, that it's recognized. So really, it is recognizing and acknowledging that this loss occurred and that it may be an emotional experience. Now, not everybody has an emotional experience to their perinatal loss, either at that time or years later. Every individual is very unique. The biggest thing I would say is refrain from making an assumption. It's just better to ask. Don't assume that because the partner is not crying, that the partner is not impacted. Don't
Right.
assume that the one who has given birth and raising 3 children already and isn't mentioning it, don't assume that it wasn't emotional. Just ask. I know that you had a miscarriage not too long ago. How are you doing? When you ask, be ready to listen. So don't ask in that, hey, how are you? I'm fine expectation. Be ready to listen and sit with them. And even being present is so powerful. Maybe no words need to be said. Maybe it's just you sitting with that person, having a cup of tea, a cup of coffee, but letting them know that you see their pain, that you care about their pain. Coming up, October is Perinatal and Infant Loss Awareness Month. And it's so important to remember, just say, I remember that this happened to you, and grant that permission for the individual to talk about it. Now, in the time right around the loss, I mean, that person may have no idea what they need. They might not be able to tell you, I need you to do this and this for me. And just be prepared for that. Asking them, how can I help you? It's meaningful to them, and be prepared for them not to know. There are simple things that can be really helpful, offering to provide a meal, watching any living children for a little while, helping with chores around the house, helping with grocery shopping, that type of a thing. Just those daily tasks that need to happen are monumental to someone who's fresh in their grief. One woman, it came to mind, she said the first time she went to the grocery store after her loss, it was overwhelming, because she said, I should be worried about the diaper bag and the hat, and is my baby going to be warm enough? But now all I can think is, am I going to have a breakdown in the produce aisle when I can't decide between which pears I want to buy? So just being cognizant of that, and offering to help, offering to be present. In the years after, remembering those milestones, those anniversary dates. This is the day the baby died. This is the due date that should have been. Different holidays are often very challenging for parents. So just even a little card or a little note, or just a small sentence, a text saying, I remember, I'm thinking of you, I'm here for you. Something like that can be very, very powerful.
That's really beautiful. And thank you for mentioning Pregnancy and Infant Loss Awareness Month. And I think you were telling me earlier at Project Poppy Seed that you're really encouraging that we let anyone we know in our lives who we know has experienced a loss, just simply letting them know we remember them, and we remember their children. That's really beautiful. I love how you said, don't assume, right? So important to do. I did have one other question in this. I was thinking that as you're describing parents who have shared their deep pain and their deep grief with you, that there may be some of us who haven't experienced that before. We're not used to that. And so it kind of comes to mind a little bit of like, okay, so we're giving permission and we're letting them know we remember, and we're willing to listen and to sit with them. But what happens if I walk away feeling, like kind of carrying this, I don't know, kind of maybe some tips for us, if that makes any sense?
Absolutely. And that's a really important part of the experience. I'm glad you bring that up, especially for healthcare professionals, because we tend to deal with loss over and over and over, and it can compound and it can become traumatizing to us as well. Yes, we absolutely carry the pain of others. So what I recommend is recognizing that it's okay for you to be emotionally moved by this experience, whether or not it is your own. And I'll even share on a personal note, when I was doing my dissertation study, I listened to story after story after story. And I was so honored to be brought into these stories, into these lives, but it was very difficult for me. And I developed something I didn't even know was possible, vicarious trauma. And that is a condition in which an individual who has been surrounded by trauma begins to experience the symptoms of trauma. So I was losing weight, I wasn't sleeping, I was having multiple health concerns, and I did not feel that I had the right to seek help because I had not experienced that trauma myself.
Mhm.
And thankfully, I had others around me who were much wiser than I, who helped me see that it's important to take care of yourself. It's important to acknowledge the impact it has on you and to seek help, especially for those of you who are surrounded by this. I would say you brought up an important point, and I wanted to touch on this. For those who don't have personal experience but want to talk with somebody or help somebody, it's okay if you don't understand what they're going through. It's not important that you understand. It's important that you know that they are going through this and that they just need you to be there and listen. So I would caution very pointed questions directed at understanding, and rather have those questions be at allowing the individual to share their experience. So it's the motive that you enter into that conversation.
Right.
Just please be cognizant of that and respectful. And then again, I know many of you know someone who has had this type of loss. I mean, 1 in 4 pregnancies, I imagine you know many. And I am grateful that there have been so many that have turned up to this conversation.
Okay, thank you. Thank you, Dr. Berry. That's so helpful. And I have one more question before we go over to the questions that I can see that people are starting to submit their questions in the Q&A box. You still have time to do that, those who are participating, because we're going to turn to them next. But first, my last question is, what recommendations do you have for future studies?
Yes, all of them. There's so much that needs to be done in this area. There have been some great advances in how do we communicate with parents? How do we improve that birth experience? What I have not seen in the literature is how do we help parents have conversations with others? How do we help parents have conversations with their own parents, with their living children, with their supervisors, their coworkers? How do they interact with their social circle? How do children respond to the loss of a sibling in the perinatal period? How do grandparents? Because it's a very complex loss for grandparents. They're grieving the grief of their child, they're grieving the loss of their grandchild, and frequently they are also forgotten in this conversation of perinatal loss. Follow-up care is an underdeveloped area as well. How do we continue that relationship and those interactions with the parents? How do we continue to support them in the weeks, months, and years following their loss? And finally, minority populations. The United States is a very large melting pot, and the majority of the studies that we have are focused on middle to upper class, educated Caucasian women. And we know that other populations experience this type of loss, lower income, lower level of education, different ethnicities. And perinatal loss is often more prevalent in minority populations than in the populations being studied. So that's a really, really important one that needs to be further addressed.
Okay, great. Well, I happen to know that there's a number of researchers who are tuning in today, so perhaps they will take you up on that challenge. It's so important. Or maybe they want to contact you and see about collaborative work together. So if we can, it's okay, Dr. Berry, if we go to some of the questions from our participants? Okay, fantastic. And remember, you can be putting your questions in the Q&A box. So here's one. One of our guests is just asking the question to just kind of remind us again, what is the time when you say perinatal loss, what is the time range that you're referring to?
Yes, that is any time between conception and 28 days following birth. So there is that time frame of pregnancy, but there's also those 28 days following birth when there is that neonate.
Okay, thank you. That's really helpful. Somebody was also asking, because you had mentioned a number of different types of reproductive losses, they were wondering if in your scoping review that if there was included in their pregnancy termination or abortion.
Fantastic question. And yes, a couple of the studies, I believe 3, did directly address termination, whether it was termination based on the individual's decision or termination of a life-limiting diagnosis. So a birth defect that the baby would not be able to survive. And what was found within that subset of perinatal loss, there are fewer supports available. There's a higher level of stigma. There is much less recognition of the grief because there is that stigma and that judgment. And the parents have much higher levels of traumatic symptoms. And so because of this, these individuals are deeply grieving a loss, and they are seeing additional barriers to receiving support, both in the medical community and within their social circle. So they desperately need support.
Okay, thank you. Thanks for pulling that out. And there's actually kind of now like I'm seeing kind of a little bit of a theme of questions around like, were you able to note any difference between men and women in their responses as you were doing the scoping review?
That is a good question. There were just over 200 men within the samples, and I believe over 600 women. So one study had up to 40% of the fathers experienced symptoms of trauma. And because men are rather underrepresented, it's not as well known. There's not enough data, but the preliminary data does suggest that yes, fathers are deeply impacted, but fathers also have additional barriers. There is, in the United States, the majority of these articles were from westernized countries, the United States, Europe, Australia. There is this expectation of the manly man to be strong and stoic, to be the supporter, the speaker, the one who is taking care of the individual grieving the loss. So not only is the father commonly not recognized as having grief, that grief is expected to be hidden. And so that what we know about trauma, unresolved grief can be embodied and then actually make those symptoms of trauma even more prominent.
Okay. And then you kind of slided into another question that I'm seeing, which is they're also saying, were you able, with the demographics, were you able to see any difference perhaps across different cultural or racial groups?
Yeah, that's a great question. And this one was a little frustrating to me because not all of the studies reported demographics. So I don't have a good answer to that question because the data was incomplete. What I can say is for those of you researchers, please collect the data. What demographics were collected, it was that primarily Caucasian, high educated, middle to upper class population. There were some studies with Latinx populations. A few participants were Black and African American. A few were Asian, but individual subgroups, minorities that were really overlooked included those indigenous to the United States in particular.
Okay. So another area of study to better help us to understand, or maybe to better equip us to be able to help individuals who may experience this a little bit differently, or maybe have different desire for how they would like to be supported. And speaking of the support, One of our participants is saying many parents or many people report fear of re-traumatizing a parent by asking, "How are you doing?" sometime after the loss. What words or strategies would you suggest for friends and families who are wanting to comfort parents? And especially, we're encouraging people to do that during October. Yeah, can you help us with that? And are we re-traumatizing them to
Yeah,
begin with? And then what are some tips that we can use?
that's a great question. And may I say, you are not alone in that fear. That is a fear that we all hold, that I hold, even with my line of research. It is possible that you may re-traumatize the individual. It is very common for strong emotions to arise. But the important thing is, just because someone may become emotional does not mean you're re-traumatizing them. What I have found is that those I ask, they want to talk. Even through those tears, it's very, very healing to them. Out of however many hundred people I've talked to, I've only ever encountered one individual who has said, "I don't want to talk about this." And if that happens, that's perfectly acceptable. Say, "Okay, just know that I'm here for you." But being brave enough to ask is really, it is important. And know that if tears come, if there's a strong anger, if there's strong emotions, I mean, that doesn't mean that you've done something wrong. That means that this person is deeply wounded and they really, really do need your support. So really, I just encourage you to be bold, be prepared for a mixed response, and just be respectful of how that individual does respond. But really, the biggest thing is to ask.
Right. Okay. Thank you. Thank you for that encouragement. One of our participants is asking, could you please clarify, did you find diabetes and cancer were a result of the loss, or were they confounders? So
Oh, yeah.
you had noted that kind of whole list of from emotional to physical. So
Yes, and that's a great question. So, diabetes, high blood pressure, cancer, those emerge, including premature death, emerged after that loss experience as a result of complicated grieving and those symptoms of trauma. So, in looking at the physical aspects of trauma, we have that heightened response within our body. There's all of those signals and chemicals that's coursing through our body that is helpful in the very short term. But if it progresses over weeks, months, years, it becomes detrimental to the body, and it results in different types of chronic conditions like diabetes, like high blood pressure, like cancer. So this was specifically found to be the result of the trauma that had emerged from that loss. And I know one I did want to mention that I had not mentioned earlier and can be triggering in and of itself. Suicidal ideation is one of those things that does emerge from this type of experience. So recognizing that a parent may become suicidal or may attempt suicide, it's important to know that that is a risk that has been documented in the literature.
well, I don't think we don't think about that, do we? We don't think about how the emotional can then with the physical resources. I mean the physical symptoms as well. And then, yeah, suicidal ideation. Thank you so much for bringing that up. A question we have, we're going to switch gears a little bit. It says, I'm wondering if there is a resource for care providers that provides supportive measures appropriate for each of the milestones that you have, or would you suggest, or what would you suggest as a providers embark on providing that type of support?
Excellent question. And I love the intent behind this question. Someone cares to address this. There are different organizations. I will say the Institute of Reproductive Loss does provide toolkits and a lot of education and resources for clinicians looking to improve this process and support parents. Different organizations, like Michaeline mentioned, FIDA is one of these that provides evidence-based practice and toolkits, highlights different research articles. There's Resolve Through Sharing, which provides training to individuals. Overall, there are some guidelines. A few articles have published guidelines, or a few organizations have published guidelines, but overall, there's nothing concrete to say, this is what we need to do, for two reasons. It's an underdeveloped area that many individuals are working on, but also each experience is very unique. So we can't have an algorithm like we do for sepsis or for a stroke or a myocardial infarction. We have to have those guidelines rather than those algorithms. On that note, I have been working with two organizations, Be Not Afraid and String of Pearls, and they already integrate trauma-informed care into their support for their clients who are experiencing perinatal loss. And together we are working on publishing an article that suggests a trauma-informed care framework for the perinatal loss experience. We're hoping to submit that by the end of this year. So there is more coming.
Good. So it sounds like we had to have a little bit of a framework right now, but that more solid, if you will, kind of best practices are going to be something that are developing right now, and that will increase. So we're almost out of time. Is there a final word that you would like to say to our participants here, Dr. Berry?
I would just like to say thank you very much for coming. I know that this is not a cheerful topic. I know that it's not a buzz term. I know that you are here because you care. And I really appreciate and admire that heart that you bring with this. It's not easy work. It is deeply necessary. And it's very encouraging to see how many truly care about this.
Oh,
and to you, Michaeline, thank you for all that you do at the Institute. It's great work that's being done.
Oh, well, thank you, Dr. Berry. And we so appreciate your innovative work and your dedication in a space where, there isn't a lot, but you're helping us, and that's growing. And we're so grateful that you could join us today, and we're looking forward to what you will be, producing for us in the future that's going to help us. So thank you so much. And I want to echo Dr. Berry's comments as well to our participants. I am so grateful for the care and concern that's shown by all of you to better understand and aid individuals impacted by reproductive loss. So we're wrapping up now. So let me just give a couple announcements before the end of the event. Please fill out that evaluation to complete the class. Your feedback is really valuable to our team. I think I saw somewhere like in the comment section, someone was asking about CE or contact hours. Yes, you can earn your contact hour for this time, but you must fill out that evaluation. That's mandatory. If you'd enjoy this event and you'd like to know more, I want to invite you to check out our other reproductive grief care courses, as well as our past Research Reveals lectures. We even have some self-care courses, and you can find those all at the same website that you signed up for this event, which is lifeperspectiveslearningsystem.com. And while you're there, you might also want to check out our new 7-course certification track. This is going to provide you foundational proficiency and reproductive grief care. And I'm so excited to announce, you could actually sign up in advance. We're doing like a pre-sale for Dr. Berry's new course. It's called Supporting Parents Following a Life-Limiting Fetal Diagnosis, Guidance for Clinicians. And it will be available to take the course starting October 10th, but you can actually purchase that course today. And of course, keep an eye out for our next Research Reveals lecture that will be coming to you before the end of the year. Again, thank you so much for joining us, and thank you for the wonderful work that you do and the comfort and the healing that you offer to those who are grieving after a reproductive loss. Thank you so much.